We're taking this, 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 we're taking with a pinch of salt.
Dear colleagues, welcome in today's A Pinch of Salt, a podcast proposed by the ERA. I'm George Kosmadakis, your today's host, and the subject is the anticoagulation of CKD patients with atrial fibrillation. Atrial fibrillation is the most common arrhythmia in CKD patients. Up to a quarter of them have a diagnosis of non-valvular atrial fibrillation compared to 10% of the non-CKD population, with higher prevalence among older individuals and those with more advanced CKD. The challenges of stroke and prothrombotic prophylaxis, bleeding events, ease of use, monitoring, availability of antidotes, and of course the price, are factors interfering in the complex puzzle. I admit that I'm a little bit confused. Until which CKD stage could I give the DOAC? What about the place of vitamin K antagonists? Some voices propose no anticoagulation at all for dialysis patients with atrial fibrillation. In order to answer all these questions, we have our host today, Dr. Frida Welander from the Department of Public Health and Clinical Medicine, Research and Development in Sundsvall Umeå University in Sweden. Thankfully, she will help us elucidate the puzzle as she has worked a lot in this subject and published a very interesting article in the Clinical Kidney Journal last year. Frida, welcome to the Pinch of Salt.
Thank you for this invitation. I feel really honored to be here and talk about this important subject.
Well, you are a big specialist because I saw that your dissertation was concentrated on this matter. So you have read a lot, I think almost everything about this matter. And
Yeah.
therefore, I will ask the first question, which is always a naive question. Why is it important to discuss today about anticoagulation and atrial fibrillation in CKD patients?
Well, there lies a paradox within patients with the chronic kidney disease. They have a high risk of thrombosis, especially arterial thrombosis, such as ischemic heart disease and stroke, but they also have a high risk of bleeding. And this risk gets higher with decreasing kidney function. So balancing these two events, thrombosis and bleeding, is very difficult. And there is really no good way to predict a stroke or a bleeding in patients with advanced CKD, since validated scoring systems like SHADS-VASc or HESPLED are unfortunately no better than tossing a coin. So it is a difficult balance, and I struggle with this in clinic every week. So it's also a very relevant topic to all nephrologists.
Well, you know, I have always tried these two scores, and they were both of them very high. So I was this was increasing even more, you know, the confusion I had about what should I do.
Yes.
And therefore, you know, we come to the next question: which are today's therapeutic options?
Roughly, you can say the options are the vitamin K antagonists and DOAC. The traditional anticoagulant treatment for patients with CKD has been warfarin or other vitamin K antagonists or VKAs. In a general atrial fibrillation population, they have been shown to reduce the stroke risk by 2/3. Vitamin K antagonists are not specifically studied in RCTs in patients with eGFR below 30, but their use is approved all the way through dialysis. They are cheap and there's an effective antidote. However, there are some problems with vitamin K antagonists. The therapeutic window is narrow, and with decreasing GFR, the time in INR range, the TTR, decreases substantially. The use of vitamin K antagonists in advanced CKD have also been associated with accelerated vascular calcification and also the dreaded complication of calciphylaxis. So there are several reasons to try to get away from warfarin. But even so, in Sweden and the Nordic countries, we have a long tradition of well-managed warfarin therapy, and we have a high quality of this treatment with a high TTR also for dialysis patients. So warfarin is still a valid option, especially if you can manage a high TTR. However, the last decade, the use of direct oral anticoagulants, DOAC or NOAC, this is the same thing, this use have exploded. The DOACs are at the moment apixaban, edoxaban, rivaroxaban, and dabigatran, where the first three are antifactor Xa inhibitors, and they are approved for use all the way down to eGFR 15, whereas dabigatran, the only DOAC that has an effective antidote, is a factor 2 inhibitor and is not approved for use when eGFR below 30 in Europe. In studies in the general atrial fibrillation population, DOAC have been shown to be equally or more effective compared to warfarin in stroke prevention, but at the same time reduce the risk of major bleeding, especially intracranial bleedings. The use of low molecular weight heparin for stroke prevention in atrial fibrillation is not sufficiently studied and is not recommended, but it is sometimes used anyway when oral anticoagulation is not possible and anticoagulation is assessed as important.
Well, you stressed some issues that are very important, the fluctuations of INR, the risk of calciphylaxis and vascular calcifications. We have some of us who have a certain age have had these terrible experiences with patients, and we have also this paradox because DOACs are not indicated in dialysis patients in Europe. EMA does not indicate DOACs in dialysis patients, whereas FDA has given the indication for the United States. Do you think that things will change?
Yes, I think it will, because we are getting more data from there are some published studies already, and there are ongoing studies. So I think in the upcoming years, we will know more.
So for the moment, what do you which is the place of DOACs and vitamin K antagonists in the treatment algorithms? How would propose as an expert in the field today? It's January 2025.
Yes.
Because, as you said, there will be studies and probably things will change. But today, what should I do?
Today, for patients with atrial fibrillation and CKD stage 1 to 3, DOAC is the first-hand recommendation. The exceptions are if a patient has a mechanical heart valve or a moderate to severe mitral stenosis. For these patients, the VKAs are recommended. But for the other patients, DOAC are the first-line therapy. But an ongoing well-managed warfarin therapy doesn't necessarily need to be switched to DOAC, especially in elderly patients where this switch has been associated with more bleedings, and this was recently shown in the FRAIL AF trial. However, if TTR is low, or if the patient wants to switch, I recommend a switch to DOAC. There are no head-to-head studies comparing the 4 DOACs, and which one you choose depends on the patient's characteristics, as well as your local tradition and recommendations. For patients with CKD stage 4, eGFR below 30 to 15, DOACs have not been evaluated extensively in RCTs, but its use is now widely spread, and from observational and pharmacokinetic data, this use seems safe and effective compared to warfarin. In Europe, dabigatran is not an option if eGFR is below 30, and this leaves us with apixaban, rivaroxaban, and edoxaban. All these can be used, dose adjusted, and I personally have the most experience with apixaban, so this is what I mostly use. Observational studies have indicated lower risk of bleeding on apixaban compared to other DOACs, but there really is no hard evidence showing superiority of any of the DOACs, and the choice should be based on an individual decision for each patient. And now to the hard part. First, patients with CKD stage 5 not on dialysis. Here, data is lacking on efficacy and safety of oral anticoagulants, but what we know is that these patients have a high risk of bleeding. No DOACs are approved for use in eGFR below 15, and this leaves us with warfarin. However, the use of DOAC off-label is increasing, but it is important to know that no studies have yet shown that there is a net benefit with this use yet. So don't routinely prescribe oral anticoagulants to all patients with atrial fibrillation in CKD stage 5, not on dialysis. Instead, try to assess the stroke and bleeding risk, and it is okay to abstain treatment to patients with the highest risk of bleeding. In CKD stage 5 on dialysis, we have more data. There are 3 completed randomized control studies comparing DOAC and vitamin K antagonists. The Valkyria trial, comparing 10 milligram rivaroxaban and a vitamin K antagonist, showed a benefit for rivaroxaban regarding a cardiovascular composite, as well as a bleeding benefit. But of note is that this study was small and had a poor time in INR range in the control arm. The other 2 completed studies compared apixaban and warfarin, but the recruitment in both studies was too low, so no conclusions could be drawn on the efficacy. What we could elucidate from these 3 published RCTs is that the bleeding risk on oral anticoagulants is high, up to 10 times higher than the risk of ischemic stroke. And in one of the studies, the rate of fatal bleedings was equal to the rate of ischemic stroke. So asking which oral anticoagulant to use in CKD stage 5 might be the wrong question. Maybe the question should be, should we at all use anticoagulants in CKD stage 5 due to the very high risk of bleeding? And to these questions, we don't have the answers yet. So what we need to do is include patients with CKD stage 5 in trials comparing oral anticoagulation and no treatment. And there are a handful of these trials going on. For example, the Swedish SAC study, and this is a prospective randomized control study comparing low-dose apixaban and no anticoagulant treatment for patients with CKD stage 5. And there is also a Danish RCT, Danward, comparing warfarin and no treatment in patients on dialysis. If a patient is not suitable for a trial, you need to try to assess the patient's individual risk for ischemic stroke and bleeding and involve the patient in a shared decision-making. In my opinion, a patient with a high risk of stroke, for example, a patient with a history of a previous stroke or TIA, who has a normal to a low risk of bleeding, should be offered anticoagulants. In Sweden, we still often use warfarin to dialysis patients, but there is, of course, also the choice of prescribing DOAC off-label. Here again, the patient needs to be informed that we don't know the net benefit yet, especially if you decide on off-label prescription. And it is also important to try to minimize other contributing risk factors for bleeding, such as concomitant treatment with antiplatelet therapy. And remember that the wisest thing to do is sometimes to do nothing, to abstain anticoagulant treatment in a setting with a frail patient with a limited life expectancy and a high risk of bleeding. Choosing not to anticoagulate is also a valid choice, since here the risk for major bleeding might exceed the stroke risk by many times.
Well, Frida, as always, we in these complex questions, we always come with the same answer, which is treat the patient and not the disease, and
Yes.
take the individual characteristics of each patient in order to have in order to make a decision that is pertinent for these patients. While we're waiting for more trials, there is a huge number of questions that are produced in this matter. That's why we did this podcast, and you gave us a photo of the actual situation, and I should stress that you are inclusive. You try to divide the patients between those who are on high risk for thrombotic events and who need probably a treatment, those who are with lower risk, and therefore bleeding is becoming more important risk factor than the cost-benefit analysis is more on the side of the risk
Yes.
rather than the benefit. So individualization of the treatment is the right answer. And I will come to my last to my almost last question about anticoagulants, which is the combination of circuit anticoagulation and oral anticoagulants. Should I heparinize the dialysis circuit or not in the patients who are under this treatment? This is a very common question between the clinicians.
Yes. In my experience, we should anticoagulate the dialysis circuit, but it seems like we can reduce the amount of low molecular weight heparin a little bit. But this, of course, also depends on the dialysis length, etc. If I start a patient on an oral anticoagulant, I often start with about a 10% reduction of the low molecular weight heparin. And if this goes well, I continue to reduce this stepwise.
So stepwise adjustment of the anticoagulant treatment by looking at the circuit, and if the circuit is clear, we stop there. In that way, the risk of bleeding probably is lesser in this group of patients. Now I will ask you to take off your crystal ball, and I will ask you to tell me, how do you think that atrial fibrillation in CKD patients will be treated in the future?
Yes, we are waiting the randomized controlled trials comparing oral anticoagulants and no treatments. I already said that, and these studies will hopefully give us answers on the net benefit on oral anticoagulants in dialysis patients. But there are other options in the pipeline, although we don't know to what extent these will be used. First, many trials are ongoing trying the factor 11 inhibitors. Factor 11 is involved in the amplification phase of the coagulation cascade, and people with inherited deficiency of factor 11 have lower risk of thrombosis, such as ischemic stroke, even though they experience more bleedings after trauma or surgery, they don't seem to experience more life-threatening bleedings. And this makes factor 11 an interesting target of intervention. The phase 2 trials of the factor 11 inhibitors have shown promising results with substantially lower risk of bleeding than the conventional oral anticoagulants. But we don't know the efficacy, the stroke preventing effect yet, and the phase 3 trials are needed for this. So please include patients in these studies as well, if possible. Also, there is an option of left arterial appendix closure. Since the cardiac atrial appendix is where the majority of the clots are formed in patients with atrial fibrillation. And in theory, this is an appealing alternative to patients with high risk of both ischemic stroke and bleeding. But it is associated with peri and postoperative complications. And at the moment, patients need double antiplatelet therapy for 3 months post-procedure. Thus, I feel it's a very limited group of patients that might be considered for this. Also, the efficacy is yet to be proven in patients with CKD stage 5 and dialysis. There is a German RCT going on right now, so I think it's too early to make any recommendations on this, other than that it's a possible therapy for patients with high risk of bleeding, and we will probably know more in the future.
So thankfully, dear colleagues, Frida has no crystal ball, and she's giving us two options: factor 11 inhibitors and left atrial appendix closure, which are very interesting options. I have used the closure in some patients who presented very big excursions of their INR because I was desperate. But I'm really waiting for these studies to tell us if it's a valid option or not. And I think that we have finished with the clinical part, and now, Frida, I will ask you the common get to know you question. If you were in a desert island, which book, luxury item, and 2 songs would you take with you?
Yes, I don't know if it's a luxury item, but anywhere I go, I bring my running shoes. So this is probably what I would bring to a desert island. About the music, right now I listen a lot to Billie Eilish. So I think I would bring a song by her. I think I would pick What Was I Made For? But I'm also a Swiftie mom. Me and my oldest daughter listen a lot to Taylor Swift together. So I think I would bring a song by Taylor Swift as well.
Which one?
I think Love Story is our favorite.
Okay, because we'll have a playlist at the end of the year, you know.
Yeah.
And what about the book?
About the book, I think I need to bring the book that I'm reading right now because I'm really curious about how it ends. So I would bring Remarkably Bright Creatures by Shelby Van Pelt. And this is a warm and really clever book, and I really recommend it if you need a break from nephrology.
I will ask you a very short additional question. Where do you work? Describe me. Describe your town.
Yes, I work in Sundsvall, in the north of Sweden, and this is it's not a small, it's a medium size city with a medium size hospital. And I also do a postdoc at the Karolinska Institute in Stockholm. And so I go to Stockholm a lot as well.
Right, right. So, dear colleagues, things are yet fuzzy, as you heard from Frida, but some trends are starting to appear. We're expecting more answers on anticoagulation treatment for our understudied CKD patients in the years to come. We hope that more studies that include advanced CKD patients will come up in order to give valuable answers to these very pertinent questions. Please stay connected to our monthly podcasts on many interesting issues available in all the main digital platforms. Take care.